Good morning. My name is Mike Miranda. I'm here with Dr. P.Tornetta from the Boston University Medical School. We're going to talk about distal femur fractures, a fracture I find very, very challenging. So we're going to look to Paul, who's an expert, to give us his advice, and we'll go through a challenging case. Morning, Paul.
All right. Hey, Mike. How are you? Hello to everybody. So this is where we stand. So this is the pattern that was chosen. And can you guys get a tight up on this? So you can see there's a little 3D model here that shows the displacement through the condyle. This is a little bit different than the normal case because this fracture really occurs oblique this way, and it's more on the medial side. So this would be a little bit more difficult to manage from a lateral arthrotomy. You can see there's a little bit of step off in the back, which you can see back here. So really the medial condyle is more displaced, at least in the current state when the CAT scan was taken. Obviously, when this is a real patient, these would all be completely displaced. So here you can see an example of what it looks like. And you know, the plan for this, you've got a couple of options. In reality, I might nail this fracture, so I might open this midline, put 2 screws across because it's fairly simple. So if I was actually in the OR, I would probably have both sets available. Today we're going to do a plating. So probably we'll do a medial arthrotomy, try to get this corner back, maybe put a little anti-glide plate along the medial side here, which is a specific plate made for that area. And then come back to the lateral side, and if we think we have a good reduction, probably just do a linear incision and a percutaneous locked plate distally. And I'm like, what are your thoughts on this?
Well, I think this particular fracture, as you said, is fairly straightforward. Simple fracture into the joint. Obviously, you want an approach that's going to give you great visualization and excellent read so that you can reduce it anatomically and then get your fixation across. You had mentioned that you might do this with a nail, and you said that that might change your approach a little bit. So then you'd go for a radiographic read as opposed to a visual read?
If I was nailing when I have an intra-articular fracture, so when I do a standard retrograde nail, it's only about a centimeter incision.
Sure.
But for anything that has a joint involvement, I'm going to open those. The thing you can't tell on fluoro is you can't tell rotation very well. Sure. You can get a lateral and you can see a little bit of the difference in condyles. When you're looking directly at it, it's fine. So for those, I do a medial arthrotomy. I move the patella out of the way. I get a direct anatomic reduction, put my screws across, and then I have to go back to the floor to figure out where the portal is because I don't know where that is under direct vision. You know?
Sure.
I gotta close it up and then come back to the portal. But I do those open.
Great.
I do those
Great.
open.
And the with regard to the plate system that you're using now, you've got it. You'll put that through your standard approach. What's your approach going to be?
Yeah. So for the plating side, probably if you don't have to see the joint, it'll probably just be a linear incision enough just to see the distal footprint of the plate. And this is the newer system. It's a EVOS large frag, which replaces the Smith & Nephew Perilock, if you've ever used those. So it's basically like every other system. It's a percutaneous system that allows you to do lock screws distally and screws up in the top. And there's some nice little toys and tricks, provisional fixation and stuff like that. So I usually go in a similar order of, place the plate, make sure that it's on bone at the top, make sure I'm out to length, put a provisional fixation pin distally, put a provisional fixation pin, and then you start to just load up your fixation. I do think it's important, too, to get either a clamp at this level or to put a 4-5 either lag or positional screw as proximal as you can get on the medial side to prevent the fracture from being pulled into valgus. That's actually the big deformity here is you can have the plate a little bit off so you're in valgus. And the other deformity that you get is the golf club. If you have the plate too posteriorly, you get medial translation. Neither one of those things is desirable.
Yeah. So what I love about that is your discussion is the fact that you're trying to obviate and sort of make sure that things go well by sort of keeping the things that can go wrong, keeping those neutralized so that you don't run into any problems. Right. And I think that that's key for any surgeon. Right. So that's excellent. Excellent discussion points. I guess we're going to move on to the lab. We'll get you in there and get you going. All right. Thanks.
I can go.